Hi, everyone. Welcome. Thank you for joining us today. I am Nobuhiko Ban, the chair of Task Group 124. I look forward to the discussion on this old and new topic, justification. So now let me share my slide. Okay, as an introduction, I'm going to give a talk about principle of justification with emphasis on historical overview and challenges. This presentation consists of 4 parts: justification in ICRP recommendations, development since 2007 recommendations, ICRP Task Group 124, and format of today's workshop. Let me start with the first part. In early days, radiation was thought to be harmful only when the dose exceeds a certain level. However, the increase of knowledge, particularly of carcinogenic and genetic effects, required caution and prudence. And it was in 1958 when ICRP referred to the balance between risks and benefits for the first time. This slide shows an excerpt from publication 1, and you can see the emphasis was placed on genetic damage. And also you can see a phrase, balance between risks and benefits. And in the latter half, it also said the balancing of risks and benefits will vary from country to country, and that the final decision rests with each country. I think this was the origin of justification as well as optimization in ICRP recommendations. This idea developed into the system of dose limitation in publication 26, 1977 recommendations. At this point, justification was clearly defined as one of the basic principles for radiological protection. It said, no practice shall be adopted unless its introduction produces a positive net benefit. And for the intervention, the decision to introduce countermeasures should be based on a balance of the detriment which it carries and the reduction in the exposure which it can achieve. The principle has been maintained in subsequent recommendations with some changes in the wording. In the most recent 2007 recommendations, the description is much simpler. It says, the principle of justification means any decision that alters the radiation exposure situation should do more good than harm. Here, the key phrase is more good than harm. Publication 103 elaborates what it means. It says, the expected change in radiation detriment should be explicitly included in the decision-making process. And at the same time, other risks and the costs and benefits of the activity should be taken into account. To put it simply, what to evaluate is benefits minus radiation detriment minus other risks and costs. And the question is whether the result is positive. But this evaluation entails value judgments, and this fact makes it difficult to provide further guidance on justification. But the situation has been changing, so in this second part, I will briefly talk about developments since 2007 recommendations. As you know, ICLP's system of radiological protection is based on three pillars: scientific knowledge, ethical consideration, and practical experience. Historically, radiation protection community paid most attention to science and experience. But in 2018, publication 138 came out describing 4 core ethical values and 3 procedural values. It is the first ICLP publication that elaborates the ethical foundations of the system of radiological protection. That means ICLP has taken a step forward to address the issue of value judgments. Another important milestone is the experience in Fukushima Daiichi accident. As you may know, protective actions or remedial actions for the Fukushima Daiichi accident were effective to keep doses low. However, health of the elderly deteriorated after the evacuation. In the worst cases, they lost their lives, and people's daily life was disrupted. The changes in the living environment brought them various difficulties, including health concern, stigmatization, community severance, and so on. And many of the difficulties arose from protective actions or remedial actions against radiation exposure. So the important lesson we have learned is what matters is not just radiation exposure, but life in the exposure situation. This lesson urges us to widen the scope of radiological protection. From prevent, mitigate detrimental effects of radiation to ensure or improve well-being in exposure situations. In other words, our mindset has been radiation dose-centric, but we should take a more holistic approach focusing on well-being. According to the WHO glossary, well-being is a positive state experienced by individuals and societies. Similar to health, it is a resource for daily life and is determined by social, economic, and environmental conditions. Based on this definition, well-being is more than an individual matter, because my family's well-being is a prerequisite for my own well-being. And similarly, my pet's well-being, my friends' well-being, future generations' well-being, and environmental well-being, all of them have to do with my own well-being. So there is no doubt that a systematic approach should be taken from a comprehensive perspective. And this application is in line with the 17 Sustainable Development Goals, which represent common societal values today. To summarize, I want to emphasize these 3 points as noteworthy developments. First, ethical foundations of radiological protection described in publication 138. Holistic approach to well-being we have learned from Fukushima Daiichi experience. And sustainable development goals as common societal values. With this background, ICLP has created Task Group 124. Task Group 124 deals with application of the principle of justification. This task group was created under Committee 4. It was approved by the main commission in the end of April and started activities in October last year. These are the current members of task group. The members were chosen according to the field of expertise, experience, and geographical and gender balance. Representatives of SLOs are also involved, specifically IAEA, IRPA, OECD, NEA, and WHO. The mandate of the task group is to deliberate on application of the principle of justification in all 3 types of exposure situations, consider all categories of exposure for humans and non-humans, take particular note of situations where radiation exposure is a major concern, and at the same time, societal and ethical values are considered to have important implications. And the task group emphasized the ethical values described in publication 138. In the work process, the task group develops a short list of situations where societal ethical values would be of particular importance. Last year, we had a discussion on this point, and result will be shared in each sessions of this workshop. And then the task group organized open topical workshops to exchange insights and experiences with those interested in this topic. And this is the first topical workshop. Through these activities, the task group is expected to clarify what more good than harm means in society today, and on what basis the judgment should be made. And finally, I will give you a brief note about today's and tomorrow's workshop. The workshop consists of 4 sessions. Today, we start with planned exposure situation, medical application, followed by the planned exposure situation of other sectors. And tomorrow, we'll have sessions for emergency exposure situation and existing exposure situation. Each of the sessions will be moderated by the moderators shown here. We have several hundred participants today. So with the platform of Zoom is used throughout the workshop. This means only speakers are visible and other participants are not visible and their mics are muted. During each session, the moderator gives an introductory presentation and then leads a discussion. In the discussion, participants who want to make comments are asked to type in the Q&A box The moderator picks them up for the discussion. So that's all from me. And if you have some questions just for clarification, I want to accept one or two of them. So if you have questions for clarification, please type them in the Q&A box. No? It's okay. Then now I give the floor to Kimberly for the first session. So Kimberly, now floor is yours.
Thank you very much, Nobuhiko. Let me share my slides and make sure they work. Hopefully everyone can see these slides. Thank you for a wonderful opportunity to talk about justification for medical patient applications. We're not talking more broadly than that. This is broad enough. And it covers, the spectrum of the lifespan. Committee 3 also talks about veterinary applications, but we're not going to talk about that today. So with that, let's talk about the planned exposure situation of the medical patient. As Nobuhiko explained, we are using the 3 pillars of the ICRP to think about this, of the science, the experience, and ethics, to help explain how we think about justification. So what I want to briefly cover today is defining justification in medicine, how it's a little bit unique, and then talk about the challenges and opportunities since the publication of 103, our last general recommendations, as we are revising and reviewing that today and over the next decade. And then how we might measure patient outcomes. There are a number of different methods that I'm going to suggest that are being done. And then use the NCRP Commentary 13 from 1995 as a way for us to move forward. So, improving how we think about radiological protection is iterative. We move forward with maybe small steps, but they accumulate over time to represent big steps. If we think about the doses we're giving our patients every day, it is so much smaller than it used to be just 10 years ago. So these are big accomplishments, but performed slowly with a whole wide stakeholder group, which has gotten much wider than it used to be. So first I want to mention publication 73, which was published in 1996, which sets out stronger guidance in medicine than elsewhere for both justification and optimization. And there are 3 levels of justification, as well as 2 levels of optimization. This publication established diagnostic reference levels for our patients. So it was quite an important document for our patients. And then I want to mention that publication 103 was in 2007, and since, well, not since 2007, but then since 2000, there have been about 25 publications on medical radiological protection. And these have been helping clarify guidance in medical applications. For example, how to develop DRLs, like publication 135. But mostly they've been topical and increasingly looking at how to integrate radiological protection in increasingly complex and systems-oriented applications, to incorporate teamwork, continuous improvement in complex environments, such as using Task Group 108. And then also a publication to recommend education and training, publication 113. So how do we think about justification for the patient in imaging procedures? We understand that the benefit and risks apply chiefly to the patient. And for level 1, as Nobuhiko has described, any exposure should do more good than harm. And we take this for granted. However, this is why a solid foundation in medical and radiological protection ethics is essential. And we have both publication 138, but now we have out for public consultation, task group 109. And we will have a workshop in a few weeks, which I encourage all of you to look into on this document. And it encourages all of us to use codes of ethics and safety culture to make patients safer. Now, level 2 is what we'll probably be talking about the most here today, and that is evidence-based imaging protocols, the use of them, the access to them, and how we can make it easier for us to practice safe and optimal imaging. And I'll note that providing electronic clinical decision support at the point of care means having it on our phones, having it on our computers, and giving feedback on how we're doing relative to our peers at our local facilities, or benchmarking at a national level. This is really important. And then level 3 is when there may not be evidence, but the individualized approach is necessary for, say, a pregnant woman or a child who can't sit still but needs some sort of specialized imaging. And just a reminder that we have no dose limits for patients, but we do need to audit how we're doing with our procedures. And on the right-hand side of this slide, I show a couple of different logos for clinical decision support systems available to us, but they are costly. And unfortunately, this has prevented many nations and many facilities from adopting these systems. Now, some changes since publication 103, we talked about the ethics, which I'd like to talk about a little more. We know that strengthening ethical training will improve justification in medicine. That's how we need to think about justification when we don't have evidence. And then we also know that there's been enormous increases in the complexity of the technology that we use and the volumes of imaging. But we've had also great work in optimization, which has stabilized the population exposures in a general way. There are some exceptions, so that there's been less focus on justification. We have increasing expectations by a number of stakeholders, particularly patients, with shared decision-making and engagement with other stakeholders, from regulators to administrators, and increased throughput. They want the information immediately. And then there are new domains of medical radiological protection research in terms of registries and artificial intelligence. There's new heavy ion radiotherapies and alpha therapies. So you can see where I'm going. It's obviously very complex. Nobuhiko mentioned that we have radiological protection core values and procedural values, which I've put on this slide on the left-hand slide. This is a slide from our task group 109 presentation from our Vancouver meeting last November. And on the right-hand side, we have biomedical ethics core values in blue. They're very similar. The task group 109 was created to try to clarify the similarities and to try to bring out the importance of the procedural values to incorporate these values in our daily practice. So the values where it says other, solidarity, precaution, empathy, and honesty are ones that we felt were important to describe and to pair with the values that we already had in publication 138. So I just wanted to mention those as a way to further explore how we can improve level 1. And then going further, there are other ways that we can work on justification in medicine in terms of continuous quality improvement. And this is further described in publication 135 and task group 108 that describes events like opportunities like collaboration, widening education and training to include all stakeholders, to learn from each other, flattening authority gradients, to create safe learning environments and safety culture, to develop registries, especially with vulnerable populations like children or radiosensitive populations, and link it to clinical data, so to know how we're doing. What are some other ways that we can assess our imaging procedures in healthcare? I want to take us back in time to a early way that was presented to us in medicine by Avidis Donabedian. He was a pediatrician and became a public health expert when he went to the University of Michigan. And he developed a quality model that could be used to measure a health facility, a hospital, qualitatively and quantitatively, that he published in 1966 that endures to this day. It is used by many nations to look at the outcomes, patient outcomes. Whoops, sorry about that. That was not meant to go forward. It was meant to go backward. Wanted to spend another moment on that to look at structure, process, outcomes. And what I mean about that is that the structure of a facility, we think about access to care and the resources available for patients. And then process could be the patient, family, and referring provider experience. So that could be surveys. And then outcomes, that's the key and the hardest part. Are we providing appropriate imaging and care? Now, other opportunities for research on justification are plentiful because as our most recent UNSCEAR survey showed, there's just a burgeoning amount of imaging done every year. And that 4.2 billion exams every year doesn't even include the imaging relating to radiation therapy or radionuclide treatments. And the majority of our ICRP publications focus on optimization, as I've said, not justification. So I think that's kind of a weak point for us. And then many publications have suggested that about 1/3 of what we do is not necessary, not just imaging, but everything we do in medicine. And a recent publication I found from JAMA 2019 demonstrated about 25% of what we do in the American healthcare system is waste. So I refer you to that publication. So those are opportunities perhaps to look at research in imaging. Another opportunity is not new, but just a demonstration of a variation in the cost of care in the elderly in the American population, called the Dartmouth Atlas. Some of you may be familiar with it. And it looks at, yes, the different, very common surgeries in the elderly after different common surgery. So after a hip fracture, it's very tight in terms of the cost and the lack of variation. Sorry about that. I want to go back. There's not much variation in how to treat hip fracture. The costs are very similar across different geographic regions of our country. Whereas if you look at knee replacement, hip replacement, back surgery, there's wide variation in the cost and therefore the way we practice healthcare. So I'll change the slide because that's distracting. Now, the other way that we can measure justification in imaging procedures is looking at some of the methods described in the NCRP Commentary 13, which came out in 1995. It introduced this discussion because of the concern back in 1995 with the rising costs of healthcare. And think about that. Today, it's so much more. And the research methods focused on outcomes, cost-effectiveness analysis research, and the efficacy model by Freibach and Thornberry, which was published in 1991. And it also discussed the limitations of randomized controlled trials for tests in general. It advocated and explained the role for systematic reviews and meta-analyses. So this is an image for the Freibach and Thornberry 6-tier hierarchical model of efficacy. The level 1 is technical performance of a modality. Level 2, which is you need level 1 to get to level 2, is the diagnostic accuracy or sensitivity and specificity of, say, CT for appendicitis. Level 3 is diagnostic thinking, or do we influence with the test result the thinking of the clinician to act on that information? Level 4 is therapeutic thinking. Does the surgeon take the patient to the operating room? Level 5 and level 6 are higher levels. Does the patient outcome have a positive outcome? And then level 6 is the highest level, or is the cost effectiveness analysis at the societal level work out at when we perform modeling. Now, there are a few assumptions here that were very important, and now we accept, I think, fairly well, that radiology is part of a larger system, of a complex healthcare system. Efficacy goes beyond quality and accuracy, which is usually what we only focus on. And the model is applicable to any diagnostic test, history, the test of time, clinical scores. So that was a quick run through of the Freibach and Thornberry model. Now, in quick summary, justification in medicine has 3 levels because patients are complicated. There are several strategies to measuring patient outcomes, but limited research training or understanding of these strategies that we've very quickly gone through. There's the Donabedian model, there's continuous process and quality improvement. There's variation in use of imaging or waste, looking for waste. There's the Freibach and Thornberry model of efficacy, and there's systematic reviews and meta-analyses. So that's a quick run through, but there may be other ways that people want to discuss. I hope we can talk about them and look into other ways that people have used or looked into. Certainly audits of whether we're performing the protocols the way we think we are in medical imaging today would be part of our justification process. So the questions that we've generated for this session are, how is the level of level 2 justification currently applied in your country or your region? when is justification more carefully individualized for level 3 rather than protocol or level 2? What are the challenges and obstacles for applying the principle of justification? And finally, what guidance would be helpful from us to improve the application of the justification principle? So that was a very quick run through of what I had. I have some scenarios if people are interested, but I thought I would stop here and ask if we could have some feedback. I've asked my radiologist colleague on the task group, Dr. Sergio Salerno, to help with the questions and answers that I would ask you to put in the chat, or I'm sorry, in the Q&A box, and open it up to the audience for comments.
Now we have already one question in the Q&A box.
Okay. Looks like this is from Alan Calvert. And I guess it's best to just read it. You can't ensure that a diagnostic exposure will do more good than harm unless you include patient time burden as an input. A good number of, say, cranial CT scans show no abnormality, but it would be negligent not to do it in case of a traffic accident or persistent symptoms. So I think what you're raising is, I'm not sure I know what time burden is, but you're talking about the value of a negative test. And that's been understudied, but I can tell you that there has been, for example, one study of the value of a negative test in terms of CT scans of the abdomen and pelvis. It's an old study, but I do know of it. And definitely we know that for trauma, CT, the value of a negative test is very important. I did have a scenario for head CTs in children. I had the importance of child abuse and the value of a negative head CT. So you're right to think about that. There's another point to make about this in that when we think about modeling the value of a test, we think about discounting. And this is a complex topic, but discounting is the value of the test today and the health effect, say, stochastic effects, the risk of cancer way down the road. And so people may want to take on that risk that may come many years down the road in order to have an answer today. And that's hard to explain sometimes to people who are in the emergency room and they're in pain. They want to know what's wrong with them. So that's something that a lot of people can't necessarily grasp, but we have to be able to explain that.
Kimberly, there is a comment from meeting host that Alan is raising his hand, so it may be possible to allow him to unmute.
I'm sorry. There's another anonymous, or should I just go to the next question or comment?
Okay.
1 second, Kimberly.
All right. So what exactly is the justification principle mean? Well, I think we talked about, or actually Nobuhiko talked about that. We have to we think about it, it's justify. It's so important that we make sure that we have ordered a test that has, for example, evidence for that test to do more good than harm, taking into account all the risks.
Hey, baby.
I'm sorry. So that is the justification principle. I believe that Nobuhiko presented that. And each situation may be different. And a lot of times the referring physician will be talking to the patient in their appointment saying, I am going to order this test, this CT scan, for example, because, and, these are the benefits and these are the risks, and then, do some shared decision-making with them. So that is, where that justification principle occurs. Sometimes they will be calling the radiologist, me, especially in pediatrics, to talk about that. I hope that answers that question. I don't know if Julie, you want to read the questions to the group, like in the next one, or if you want me to be doing all the talking. Okay, I'll do the next question. In Ireland, level 2 justification is carried out by a competent authority, which is informed by evidence synthesis and some input from an expert advisory group. This is a really good point, and then you provide a reference. Thank you. This is also true for many nations where there's appropriateness criteria or referral guidelines, and then the insurance or regulatory bodies provide, they allow for the imaging to be performed or reimbursed in our country, for the patient. So you're right, but there's sometimes there's no evidence for very rare diseases or rare events. So I think I wanted to ask in that situation, what do you do? The next one is Eva Freiberg. What do you see for health technology assessment as a tool for decision-making for level 2? I think those are really, that's exactly what we do. The health technology assessment is performed up front, sometimes before expensive technologies are allowed, new technologies are allowed to be approved for patient care. So for example, the alpha therapies in medical imaging are going to need that. I don't know if you want to give an example, Eva, of that. Okay, we'll go to the next one, which is what the data tell on occasions where exposures become many times more than expected or planned due to the need of the investigation or treatment. Not sure I understand that, but maybe what you mean is that the individual situation, it's a level 3 justification. Maybe you're saying that there may be an individualized situation where the dose is going to be higher. Is that what maybe you can speak, you can unmute, and you can describe what you mean.
Hello. My question is, you will have the data world over in the medical field. Is the situation or number of cases very large where the exposures turned out to be much more, much higher compared to what was planned when the initial investigation or treatment started using radiation exposure.
Well, what can you give us a little more information about what, I mean, that happens. It happens if, say, a child was moving and you may have had to repeat something in fluoroscopy. If there was an equipment failure, if there is an error by the technologist or radiographer. I mean, I can think of scenarios where that might happen. Is that what you're referring to?
Yeah, I'm talking about the same. Is the situation that very bad? I mean, such cases are very large. You will have some data available with you.
Well, there are also misadministrations of radionuclides, and that's a significant error that needs a safety evaluation and disclosure to the families, the patient. I mean, I think, yes, those are situations that need investigation or treatment. Or, you know, if the process wasn't followed, if a normal protocol wasn't followed, then in evaluation, or, you know, if there's potential patient harm, then we usually have a protocol in place to look at why that happened.
Okay, thank you.
Okay, thank you.
Okay, Kimberly, now we have many questions. So Julie will read out the questions, and when necessary, the meeting host will unmute the questionnaires. Okay.
Great. Thank you.
So
Julie, please.
Sure. So I'm going to go to the, let's see here. Okay, we have a question. How can we apply justification in medical doctors always find x-rays as screening for all the patients coming to the hospital, especially during the pandemic? Is it still considered because there is a doctor prescription, but the action is no longer justified?
I guess that what you're saying is they can get away with ordering something because there is a clinical indication for it, but it really isn't justified. It sounds like that's the question.
Yeah, that's my understanding.
So they can get around the system, and that's typically why we have waste. I can say that, you know, one of the things is that so that it's kind of like there may be two issues at work here. There may be that we may not know enough about the patient to really make that judgment. So when we perform retrospective analyses, which there have been some studies saying that this wasn't justified, and I think we have to be careful about that. When we look from the outside into a system and say, oh, this study wasn't justified. I actually have some concerns about those because we don't really know what was happening when that study was ordered to try to figure out what was wrong with the patient, say in a hospital or in an emergency room. That's my first concern. My second is they may have, you know, ordered it and put that clinical indication in to get something done for a patient that had a different problem but needed an answer. So that's my only concern about this question, because patients are complicated and they may have something else going on and they need that particular study, but the clinical indication isn't on the list.
Kimberly,
Yeah, that makes.
Kimberly, may I add just a point on pandemic situation?
Yes, Dr. Salerno, another radiologist.
Yes, because I work in Italy, so we live on our daily life, the pandemic situation, and probably have done a lot of mistake in justification because we were completely not prepared in this evidence. But I think we learned a lot especially reducing number of CT and X-ray, as the question is. A lot of X-ray and CT examination were done at the beginning because we were efforting something that we don't know. That's the question. But we learn, and now the number of examination decreased a lot for this reason.
Okay.
Great, thank you so much. So I'll move on to the next question. Do you think there needs to be a clear distinction between level 2 and level 3 justification, and what informs these justifications? And the typist provided an example. For example, it seems inappropriate for level 2 justification to be informed by audit, as you mentioned, as it should be justified before being generally adopted, unless you are unjustifying something, I suppose. Whereas audit might inform individual justification issues within a center and help radiographers, clinicians to improve their practice.
That's a good question. I think you need both. I think, we can have all the policies in the world, but how do we know if we're following them? So, for example, we need, repeat retake rates. We need to track that. How do we know how many X-rays are being repeated of the shoulder? That's a particularly difficult X-ray to do correctly. And an individual radiographer technologist, there's a lot of variation. Some individuals are really good at it and others are not. And so we need to know if they need some training in it, for example. So we need to know the retake rates. Equally, if we have a great evidence-based protocol, but we aren't following it, that's on us to make sure we're doing it. I can tell you that I reported on the general region of pediatric abdominal CT and how often individual adult facilities were doing more than one pass or phase through the abdomen, which is not the image gently, recommendation. And it was something like 55% of local facilities were doing multiple passes through the abdomen for abdominal pain. So, we're not exactly following what is part of the appropriateness criteria.
Great. So the next question, our C4 colleague, Anasbit, should justification be influenced by previous exposures to radiological diagnostic techniques? How important is it to have a good record of exposure for patients attending different clinics for different tests?
Through good information technology. That's the answer. And that's why I think that often our systems fail us. So, our patients are at risk today because we have huge staffing shortages. We have increasing throughput demands and less communication amongst, we're in a dark room. Sergio can speak to this. I'm not practicing, but I talk to my colleagues a lot, and they, there's this incredible pressure to read very quickly, but with poor IT. And so this puts the patients at risk, and we don't have the information that we need to make good decisions. So we need the prior study, and we need the prior protocol, and we need connectivity.
I completely agree, Kimberly. We also need before perform the examination.
Well, yes, right.
Thank you. Okay, we'll move on to the next one. Dr. Rachel Lane asks, in occupational settings, dose limits and dose monitoring are in place. Are there similar protective measures in place for patients? For example, a childhood cancer getting multiple CT scans could quickly accumulate to doses greater than 100 millisieverts.
Right, and they do, particularly if they get radiotherapy and they're getting cone beam CTs with their, they can easily get 35 cone beam CTs, and be cured of cancer. And so we have a task group 116 looking at that and looking at protocols for that, because there are no protocols internationally for that imaging related to the healthy organs around the tumor. So we don't have dose limits. However, we have best practices. We try to have, there's such a culture of safety around children that pediatric practitioners are very careful for this aspect. And also hence the Image Gently campaign, because the adult practitioners are less so. So this is an ongoing effort to look at vulnerable populations. And we try to use ultrasound and MRI instead of CT when possible. So that's the best answer I can give.
Thank you. So the next question we have is from Alan Calvred. He states, I have a concept of disposable life. The time you can spend doing what you want rather than what you must. We can assess the life shortening of a diagnostic radiation exposure and also how long we would have to work to pay for an alternative or lose work with sickness or waiting for it. I've applied this to chiropractic x-rays versus MRI for lumbar spine studies with interesting results.
Okay. I think, there are, in the Monte Carlo modeling of cost effectiveness analysis, there's a quality, there's also a disutility, but I haven't seen that particular paper, so we'll just have to look at it. There's definitely, you have to know the perspective when you do cost-effective analysis. Is it the perspective of the patient for lost time of work? Is it the society? Or is it the healthcare system? So you're just bringing up an important point. And I'll leave it at that.
Yeah, if there are any interesting papers, please do put those references in the chat. The task group will look at them. Okay, so the next question, who's responsible to apply and monitor for justification in a facility, like at a healthcare facility?
Right, so that depends on what country you live in, because many places the justification process is a shared task between the referring clinician and the radiologist. In some places, it's the radiologist alone. So that's a really good question. So I'll leave that. Yeah.
Yeah, shared responsibility.
Yeah.
Okay, our next question is from Alicia Marouk. Are there any additional considerations you would recommend for alpha therapy as opposed to diagnostic procedures? Perhaps you could share some references.
I think that, whenever the dose or the risk is higher, we're going to have, more care looking at justification. So that, but I think alpha therapies are on the newer end. So we're still in the process of it. There's still research being done. So I don't have any.
Great. Okay. The next one, Alessandro Hernandez is asking how to apply the principle of justification in a medical research in nuclear medicine, where it's important to compare images of sick patients and healthy patients to evaluate the performance of the research. Is the exposure of healthy patients always justified, or should the other two fundamental principles be applied?
Now you're talking about biomedical research, and that is part of it. It is actually required to get approval as part of technology assessment of new drugs, new radionuclides, at least as far as I'm aware, in the US, to get them through the FDA. So there is healthy volunteers. And so, yeah, I would say yes.
Okay, another assessment question. HTA is a formalized method in Norway, and the Radiation Protection Authority is part of this system to address radiation protection issues. HTA can be made at different levels: national levels, full and rapid HTA, and local levels at hospital, less extensive. All new radiopharmaceutical methods must have an HTA before it can be implemented.
Right, I agree. Now we have an interesting system. We have some HTA out in states like California, Oregon, Washington, and we have some federal ones. However, they have different, they have different levels at which they operate. So I think there's more formalized methodology outside. Well, each country has their own way of doing it.
If anybody wants to add in the
App.
QA what their country does, that would be of interest to the group.
It definitely would. Yeah, I'm aware of some
Yeah
places, but not all. And yeah, there's certainly heard
okay.
of. Yeah.
So the next question is interesting. Can you clarify more on the teamwork approach in justification? So we had just discussed that a little bit, but could you elaborate some more?
Well, most of the teamwork approaches that we've focused on in Task Group 108 has been on the optimization and the core team, and then the, in setting up protocols to make sure they're appropriate. But it's really on the communication. So I don't have a lot to say about that, but it's mainly making sure that we're communicating and doing the shared decision making. And it is discussed in Task Group 109 in terms of code of ethics and the radiation protection campaigns. So we have a workshop on June 2 and 3. So you can go to the ICRP website and sign up for it.
Okay. Okay, I just want to make sure that everyone, I'm supposed to be sharing these questions. My sincere apologies. So I'll read them and then I'll share them.
It's okay, Julie. Nobuhiko's been doing it.
Oh, wonderful. Thank you so much. Okay, so we'll move on to the next one. Thanks, Kimberly, for explaining the justification principle. Since you're talking about medical sector, which, as you said, there is no dose control, and we never record the radiation exposure for patients. Therefore, this should be applied on government level, for example, to enforce using MRI whenever it can replace CT or X-ray, and not let the insurance company go to the cheaper option, which is for CT, for example. There is no point to try to explain to the patient when he doesn't have any other options.
Okay, well, I'll just say this is a quick point of information. The basic safety standard says that we do need to record the radiation exposures in the medical record. We don't do it often, but it does say that we're supposed to. And in Task Group 109, we make a main point that we should disclose radiation doses if patients want that information, with the caveat that if it will make them more anxious, we have to do it in a way that's appropriate for them. So are there more details in the draft, which you can look at if you go to the website and you can comment on it? We have key messages, about 30 embedded in there. And it talks about, how to do it, when to do it. And one of the things we talk about is that this gets into a long thing about ethics. What is our ethical duty to stakeholders? And we make an important point that it is our duty to disclose and make available radiation exposures in medicine. And we should not be afraid of doing that, but we have to be able to do it in a way that it is comfortable, or we meet the patient at where they are. So I'm making a big point about this. This is our ethical duty, and we can't shirk it. And, we've been always saying that people are afraid of radiation, but look where it's got us. I think we've got to stop being afraid of talking about radiation because it's gotten us nowhere. And we've just got to make it a part of normal medical practice to talk about radiation, just like we talk about everything else goes in a medical record except radiation. Why do we get a pass, but nobody else gets a pass? Everything else goes in the medical record. And with that, I will let you go on to the next question, Julie.
Yeah, really important points there. Definitely agree. So the next question, thank you for the opportunity to be part of this workshop. I would like to comment that I think the shift should focus on the doctors and their knowledge of this topic. We as radiographers and radiologists seem to know the risks. However, do our interprofessional colleagues really understand the risks? I think it should be a multidisciplinary team approach. Do you have any comments on that?
No, I agree. I actually think that people, the physicians in general, I think they really are beginning to understand, not all the specialists, but a lot of them. For example, mammography, the people referring for mammograms really, do understand the benefit risk. That's so that, they know that that's important for their patients. And I think we have to remember there are other risks besides radiation that need to be taken into account. And there are benefits that they know about for individual patients. So anyway.
That's actually our next question. Radiation risk is often quantified, but benefits and other detriments are rarely quantified. Are there any quantitative methods to assess the whole?
Yeah, actually there are. We know a lot of risks. We know the risks of contrast media. We know the risks of contrast allergy, contrast nephropathy. Those have all gone down, and contrast extravasation. So we have data on that. Those are safety issues we're asked to track. So I think, we do know those in terms of risk.
Great.
Yeah.
So this is a very, yeah. This next one's very specific. Some orders for X-ray radiography for extremities are ordered by ER nurses during triage. So for some cases, how do you implement justification here?
Well, that's really easy. You make a protocol, and this is done, definitely done in the US because we're just overwhelmed, right? Our systems are overwhelmed. And I think it's done in other places too. For example, well, I won't say where, but if we have an evidence-based protocol that allows them to do it in certain situations, and then we audit that, I think that's the one way of trying to manage that process. It's not perfect. I can tell you that it is a problem.
So would you say that that also applies to radiotherapy exams? Because like having a protocol in place. So the next question was, are all imaging exams justified for patients prior to their radiotherapy?
Nurses can't order radiotherapies.
No, but just prior to the procedure.
Oh, I see. I can't answer that in every place. I can just say they have to be looked at. They're mostly individualized. There has to be a dose calculation. and there has to be a double check of the dose, of that dose calculation. So I would say in general, the answer is yes.
Okay, and this next question is more of a conflict question. How do you convince someone in the medical field when we know their demand investigation is unjustified, when they ask for irrelevant investigations in radiography?
So that's a really good question. And I would say that it's very difficult. Once people have it in their head and they want to get it done, it's difficult to convince them otherwise. If they, especially, and patients, for example, if they've been told they're going to go to the emergency room to get their x-ray, then they're going to get their x-ray. If I can put in the background here, can I advance my slide? You know, let me show you this slide. If everyone can see this slide, this is a slide of an ankle. One of the 3 views of the ankle that we get when we have ankle pain. Someone's had a twisted ankle and they have a swollen ankle, and we know when ankle x-rays are valuable. We use something called the Ottawa ankle rule. It works in children, it works in adults. Very strong evidence for you know, the physical exam you do before you order an ankle x-ray series. Yet we do a million ankle x-ray series all the time, regardless of what the physical exam shows, right? So this is, why do we do it? We do it because the emergency physician knows the patient's expected. It has little cost and it has little radiation effect. You know, the radiation dose is tiny, so the risk is tiny. And the time it takes them to explain that this is not justified, it's not worth it for them. So, I mean, I've had many, many discussions with my colleagues about this. So I hope that that makes sense.
Yeah.
Okay.
Okay, the next one is more of just a note, but I'll read it out loud for everyone. In many European countries, radiographers also share the justification, and I think that means the responsibility for justification, and can be key in preventing unjustified exposures, or can determine when and how many cone beam CTs, for example, are taken. So that's a great example of teamwork that we were mentioning before.
Great.
And the next question, on the 3 pillars of the system of RP, science, ethics, and experience, I'm just wondering, what are the pillars standing on? I think they stand firmly on knowledge management, without which they would collapse. Just a way to emphasize on the importance of knowledge management. What is your take?
Oh, that's a great point. I mean, I think we're at this, the problem we have is that, again, I think our systems are not providing us with the most current approaches to IT and sharing that information and giving us feedback. I think the problem we face today is that, you know, we don't know how we're doing. Or by the time we understand how we're doing, we get quarterly reports, when in business or in, you know, in manufacturing, it's immediate. And that's where we want to be. We want to know immediately when there's a problem, not, you know, 6 months later, or you know, a quarterly report on our Alara doses. We need to know in a more, you know, immediate sense of when there's a problem. And you know, sometimes those reports are available, but we don't hear about it. We sometimes never get feedback on how we're doing relative to our peers. And yet the data are there in the system somewhere. So it's just buried somewhere. So that's just a point I'd like to make.
No, that's great. Thank you. And I think since we'll just be very cognizant of time, one last question that I have here. is, can we establish justification limits as a standard to be used?
I think that's a good question. I think we need to talk about that because I think, you know, my colleague who was on Committee 3 for many years and is a medical physicist, Madan Rahani, has developed many papers showing that a tiny percentage of our patient population, mostly adults, get very high doses. They get recurrent imaging, over 100 millisievert doses within a year to 5 years. And it's something that, you know, we need to think about. We need to look at, you know, why are they getting such high doses and for what purpose? And, you know, we don't necessarily need to have a dose limit, but we do need to think about how to come together as a community and think about how to address this in a way that involves education, training, feedback, special protocols for these populations. So that's
Great.
some thoughts, yeah.
I don't see any more
Okay.
questions in the
Yeah,
chat, so pass it back to Nobuhiko.
yeah, thank you. And now it's time to close this session. And thank you very much for everyone for your comments. And thank you, Kimberly, for your answers. And do you have any final words, Kimberly?
No, I just really appreciate the Q&A and everyone involved. It just makes us gives us many things to think about. Thank you very much.
Thank you. So now it's time to move on to the next session. Now I give the floor to Andy for the session 2.
Yeah, thank you, Nobuhiko, and hello, everybody. I think Charlotte's going to share the slides, so thank you, Charlotte, for that. So, yeah, hello and welcome, everybody. My name is Andy Mail. I sit on ICRP's Committee 4, and my day job is working for the environmental regulator of the nuclear industry in England, the Environment Agency, and I'll be focusing over the next 20 minutes or so prior to discussion on planned exposure situations, all of those situations other than non-medical. So a very, very broad topic to address. I'm not going to be focusing so much on the principle itself, but very much so on the application of the principle as part of the ongoing review by ICRP of the whole system of radiological protection. So it's very much in that context that we'll be talking about planned exposure situations. So before we move on, just a quick reminder of what the principle is. I know that Nobuhiko introduced it and we touched upon it again in Kimberly's session, but it's all about making sure, if we can, that there's the net benefit of a new practice that involves radiation or radioactive substances, that net benefit to individuals or to society at large outweighs the radiation detriment. So a quick reminder there of the principle. So on to the next slide, please. So the objectives for this session are firstly to set the scene and set a bit of the context around what is a very wide range of planned exposure situations. So situations where the proposal is to add a radiation exposure rather than to remove radiation exposure. So we're looking at all those situations that might occur other than in the medical sector, which we've already looked at. So we're going to have a quick look at what sort of practices we're talking about, what sort of scenarios we're talking about, and then I'll introduce what for me really in many situations is a very complex challenge to evaluate justification in these in this wide range of situations. And then once I've done that, once I've set the scene, we'll move on, as we did with Kimberly's session, to consider a set of guiding questions, and which are listed there on the screen. They're very similar to the questions that in the previous session. We'll use those as a guiding framework for our discussion. So on to the next slide, please. So Nobuhiko has already alluded to the rapidly changing context in which justification decisions need to be made. We've already touched on that very briefly in the medical sector, and what a wide range of issues and were discussed there, and it's also the case here as well. So we're all aware that we are facing a climate emergency, for example, with the need to progress decarbonisation across our economies globally. We're experiencing various health crises globally, COVID being only one of those. And also we're facing pollution and biodiversity crises as well. And in addition to all that, we're also seeing great changes in the way that people communicate and the way that information is disseminated throughout societies. So we also now have the advantage of people potentially being better informed about risks and benefits, and more able to contribute to evaluations of justification. So on to the next slide, please. So I mentioned earlier this wide range of scenarios that we can potentially address here, and this is kind of a list of some of the prominent ones. The first one is in relation to the use of various technologies which in the energy life cycle. So we're all very familiar with nuclear energy using fission technology, which has been around for several decades. And here we're concerned with, or should be concerned with, the whole life cycle of that civil nuclear energy production. So that's everything ranging from the mining of the raw materials through to the production of nuclear fuels, the generation of electricity or other forms of energy, through to decommissioning and waste management. And so ideally all those parts of the life cycle should be considered when we're looking to balance the detriments and the benefits. And as some countries now are also looking forward to the potential for fusion energy as part of a low carbon energy system. And again there, the whole life cycle of that energy production should be included in consideration of whether it's justified or not. We've also now got space travel, so we've got exposing members of the public potentially, and also professionals to higher radiation doses potentially in space. We've also got nuclear propulsion systems potentially for space travel as well. So there's that whole area of space travel. There's also the naturally occurring radioactive materials industries. So those industries where radiation exposure is almost a byproduct, if you like, of those industries. For example, we will be expecting greater mining, for example, of lithium for the renewables and solar power energy systems. And so, those kind of industries potentially are of interest as well. So the next item, defence, that's something we're not going to go into, I don't think, in any great depth. But putting weapon systems aside for a minute, there's also use of radioactive materials in other areas of the defence industries. So there's a question mark there about the level of justification in those cases too, potentially. The next one on the list touches a bit on the previous session. So this is about potentially the production of radioisotope for medical uses, or indeed for non-medical uses as well. So that's one other area. And this next item on the list, non-medical imaging, is in relation to the use of various scanning technologies that are used for security purposes, potentially at airports, in customs uses, and potentially in other areas as well, like medico-legal procedures, and in sports performance related uses as well. Research and education, we all know that radiation and radioactive substances are also used here too, and these uses require justification as well. And then finally on the list, consumer products justification, and we'll come back to that on a later slide. So next slide, please. So I mentioned civil nuclear energy, and this is an area where it is associated with some significant issues in terms of how we go about justification, because of the broad, widespread geographical nature of the industry, and also potentially its long-term benefits and detriments. We all know that, or it's commonly accepted that nuclear power is a low carbon form of energy, and it's increasingly being looked to provide, part of the solution of decarbonising industries across the globe. But it brings into question the sustainable management of the whole nuclear life cycle, and whether and to what extent justification decisions need to take into account that sustainability aspect. I've mentioned the long-term nature of this use of radiation and radioactive substances in terms of the benefits and the detriments. It's normally assumed that waste management is or should be included as part of the justification consideration for nuclear power. But this brings into play consideration of very, very long-term detriment potentially, and how we go about assessing that as part of justification. And then there's also the concern about to what extent waste management in the long term has been adequately considered as part of justification for nuclear power programs, or indeed specific uses of nuclear power. So next slide, please. So on to justification process. So I wanted to just set out in very brief terms the typical elements of a justification process and what it might look like in various countries. This simple flowchart is largely based on guidance from the International Atomic Energy Agency, a very good publication, GSG5, which gives guidance on how the justification principle should be perhaps applied. And this flowchart is a summary of the information in that guidance. At the top of the process there, the justification will normally be initiated through some kind of change identified in industry or use of technology, or indeed by a specific application being made by an organization, a potential user or developer of a new technology. And that application would typically be expected to set out the full range of benefits and detriments associated with the use of that technology. Then there might be some form of initial review, which may involve setting up some form of advisory body if required. And this might typically involve experts of various kinds, government departments, and ideally members of the public as well in some cases. And so then following that, there will be a more in-depth consideration and evaluation of the case, the justification case for that new use. And this should ideally involve consultation with interested parties as part of that evaluation of net benefit. And then, of course, there'll be some form of report and recommendation produced, which will then lead on to a decision. And normally, justification decisions will be made by some public authority of some kind, either a government department for perhaps those big picture decisions, or perhaps by a regulatory body in some cases. And then, of course, there'll be that decision will be communicated to the applicant. And if the application is successful and the new practice or the new use has been deemed to be justified, then in the other radiological protection principles will be applied through various other mechanisms in regulatory terms normally. And then finally, transparency and records, very important to make sure that justification decisions related to any of these new practices are transparent, and that the records are kept for future reference in case they're needed in the case of a change in the future in the efficacy of those technologies, or indeed if there's new information on benefits and detriments that needs to be taken into account. So next slide, please. So just a brief summary of how we do things in the United Kingdom, very briefly, just by way of example. The justification process is enacted through legislation, a set of regulations that we have in the UK. The duty to make the justification decision rests with government, but recognizing that the decision should not be made by the person or the department which is also responsible for promoting that technology. So in the case of nuclear power, for example, the decision has to be made by a government department that does not have responsibility for promoting that nuclear power program. The requirement for justification is placed on or is relevant to all new practices proposing to add radiation exposure, and also where existing practices need to be reviewed in the light of new information about the efficacy, the effectiveness of the technology, whether it be a nuclear power system or a medical procedure, because medical practices are covered under this as well. If new information is gleaned on that, or if the consequences of the use of those practices changes significantly as well. The regulations also prohibit in certain cases the deliberate addition of radioactive substances to goods, the activation of materials in products and the import and export of certain goods in certain cases. There's also specific requirements around non-medical imaging, which I referred to earlier as well, some specific requirements there. And one of the outputs of these regulations is a public register of justified practices. So anyone can see what justified practices we have in the UK at any one point in time. So that's just an example there of how things are done in very much a summary terms. So on to the next slide, please. So I alluded earlier on in my talk to the fact that justification in many of these non-medical areas is very complex, as it is in medical too, and so it potentially involves a wide range of practices, which can, in some cases, I think there's somebody not on mute. Could everyone go on mute, please? So the practices can involve public, worker, and environmental exposures. So you know, we're looking at potentially one or more of those types of exposure categories. Differing scales. We touched on the concept of different levels of justification in the medical sector. That is also potentially the case in non-medical as well, because you know, we have these what we might call big picture justification decisions related to, for example, national policies on energy or nuclear power programs, right down to specific proposals for specific uses in very more tightly defined practices. We've got potentially wide spatial and temporal domains operating in this area as well, which makes evaluation extremely challenging. And I've touched on that in the next bullet point. So wide range of potential detriments and benefits, a challenge around whether and to what extent those can be quantified or not, and if not, then the how we go about qualitative evaluation of those detriments and benefits. There's a different economic and financial models that we can apply to these questions, including valuing benefits and detriments into the future, and for example, how we discount costs and benefits, for example. There's the framework of the UN Sustainable Development Goals and how those might provide a backdrop and framework for justification decisions. And then natural capital and ecosystem services. Some of you may be familiar with these concepts, many of you may not be. This is all about how we value the environment and environmental and natural resources as part of justification decisions. And on top of that, there's the considerable uncertainties that we need to grapple with too in this area. Another challenge is new and significant knowledge and post-justification. So what happens in the case of big justification decisions, positive decisions? What would happen if new information came to light that seriously challenged that position? Is another challenge which could or may not happen in the future. Ethical issues. Justification is about either individual or societal benefit. So it could be one or the other or both. If a decision is more around societal benefit rather than individual, then there is the question mark over whether that's just in terms of impacts on individuals and how that should be weighted against societal benefit. So that brings into question the ethics around the utilitarian versus egalitarian perspectives. And then finally, there's the kind of relationship of justification, ensuring its value, making sure it works as an effective part of the system of radiological protection alongside optimization and limitation, considering how those three operate as an integral part of the system. So next slide, please. The final slide you'll be pleased to hear, I'm sure. So we're going to enter the discussion phase now. I've repeated the 4 questions for people to consider, and questions that we as a committee 4 and task group 124 are particularly interested in hearing your views on. And then the final bullet point there is obviously interested in hearing other questions from yourselves. And I've just elaborated on that. As Nobuhiko said at the beginning, you know, there's we've had the UN Sustainable Development Goals introduced in 2015, and there is a question over whether these would provide a helpful framework for considering justification in the future. So I will stop talking there, and I'm hoping that Julie can help me with the question and answer session. Thank you.
Do you want me to leave this slide up?
Yes, please. Yeah, that would be helpful. Thank you, Julie. So I'm going to open my Q&A now. I think there's only 3 questions on there so far. Bamboozled everybody.
Great, thank you so much,
Okay.
Andy. I'll read the first one out for you. It's long, so stick with me. It is not straightforward for ICRP to provide guidance with regards to the application of the principle of justification. This is indeed a regulatory responsibility that reflects political orientations of governments, reflecting national priorities. It would be nice, however, if ICRP provided guidance on justification procedures, and even more on the scope for applying this principle in relation to other principles, more concerned with tolerability and acceptability of exposures, rather than the practices that cause exposure. For instance, currently policies with regard to the clearance of materials arising from practices in which they might be contaminated, for example, at the time of dismantling of an MPP, relate to the triviality of risk rather than to whether the recycling or disposal of such material is economically and environmentally beneficial. It is important to get the vocabulary right, for instance, on words like deliberate addition.
Well, I'm pleased there's no question mark there. But, yeah, it's not a question, but it's a really good point from Augustine. Thank you for that. It isn't straightforward to provide guidance in this area, especially for ICRP, who sets that kind of framework. I did allude to earlier the very helpful IAEA guidance, but there is a need for national authorities around the world to provide more guidance in this area. I do believe one of the things that we've been looking at or will be looking at in the task group 124 is to look at the types of national guidance that is actually out there at the moment, and to see how countries are guiding those decisions. So I do agree that the onus does rest partly with national authorities, because it's only in the context of those national socioeconomic environments that guidance can be framed. Having said that, I think you're right, Augustine. Terminology and vocabulary is very key, very important as well. And you mentioned a specific case of clearance, and as you say, perhaps that relates very much to the question of whether the radiological risk is classed as trivial or not, rather than a justification issue. I mentioned earlier that waste management aspects of practices should in theory be covered as part of the justification decision up front. So when we're looking at the management of waste and materials from clearance, then that's where other principles such as optimization and limitation and indeed exemption and clearance kick in. So thank you, Augustine, for that. We'll log that point, and thank you for the contribution.
The next question we have is, when it comes to ethical issues and the point about utilitarian versus egalitarian, how do you ensure that decision-making is robust to changes in government and perhaps more neoliberal ideologies?
Gosh, it's a very good question. I don't, if I'm honest, I don't have a great answer to that, because it's something that, you know, we've all been thinking about as part of how justification is implemented, and as I said, it's part of that complex challenge where we're dealing with decisions which have very long potential timescales and an impact on future generations. So, you know, the important thing is one of the important things, I think, is to make sure that sustainability and sustainable development goals are adequately factored in from the very start. Yeah, no, I'll be very interested to hear more from that question. I noticed it was anonymous, but yeah, the philosophical and ethical question marks over justification over long time periods is still very much a live issue.
Great, thank you for your thoughts on that one. Okay, so the next one is from Tristan Barr from Canada. IAEA GSG5 explanation of the justification process is familiar to regulatory bodies that issue licenses for the use of licensed radioactive materials. That decision point where justification might be applied does not really exist for uses that are not licensed. Examples of non-licensed practices could include mining industries where norm is a byproduct, air travel transport where the source, like Cosmos, cannot be regulated, or even radon doses in homes. How could we apply the justification principle in cases where there is no regulatory body responsible for licensing of the source?
Yeah, I think that's a really good question as well. And for me, it highlights potentially the gaps, if you like, in application of the justification principle. Personally, it's not clear to me whether justification is applied consistently and comprehensively across the globe, and for me, that's part of the task group's job, is to kind of have a look at that. So I think you know, if there are gaps in national frameworks where this isn't being done, then at the very least, I think there needs to be, and this is a personal view, there needs to be a documented reason for why such planned exposures are not being subject to formal justification.
Okay, so the next question. Risks during the making, storage, and transportation of radioisotopes, including accidents or thefts, are really taken into account for justification in their applications in industry.
Okay, yeah.
So perhaps how are the risks taken into account?
Okay, thanks for that. Yeah, and this relates to the point I was making about life cycles, which is a challenging area, particularly where life cycles for a practice cut across several national jurisdictions as well. So it's, you know, it's an illustration of that point, and also it is relates to the fact that all exposures, whether they are potential or almost guaranteed to occur, if you like, are included in the assessment, and they both all sorts of exposures should be included in the assessment across the whole life cycle. So yes, so theft, you know, the risk of theft, the risk of an accident in transport or in operation, all those things should in theory be included in the evaluation. it's very challenging because, as I said, if that life cycle cuts across national jurisdictions, which it will do for nuclear power life cycle, for example, then it's a very challenging subject.
Great. And we have one final point from Augustine. So with regard to sustainability, which is indeed a very important principle for environmental policies and relates to the principle of justification, it would be very useful if ICRP provided guidance on this interaction.
Yeah, thank you, Augustine. Very good point, which I wholeheartedly agree with. We've had quite a few discussions in ICRP circles in recent years about how sustainability should be referenced in the system of radiological protection, and that's work that's ongoing. Personally, I want to see, I would like to see better reference to sustainable development goals in how justification and optimization and limitation are all defined. So yeah, absolutely agree. Thank you.
Okay, I think we have time for one more question. Like optimization, can we also not say justification, economic and social factors taken into account?
Absolutely, very much so, and economic, environmental, social factors, in the same way that optimization expects those to be taken into account. Absolutely, justification should take those into account, and ethics and all of those things. And as ICRP and others have said before, when we're looking at big picture justification issues, we're dealing with issues that go much wider than radiological protection, and quite often radiological protection will be a small element of the decision making. So you're absolutely right, and the definition of the justification principle, talks about net benefit overall, and the inference there is that we're looking at socioeconomics, environmental, and all of those factors. So yes, I absolutely agree.
Okay, another one here that we have, utilitarianism and egalitarianism aren't opposed. Utilitarianism, a family philosophical ethical theories based around the maximization of happiness or some other value. Egalitarianism is a political idea that all people are equally deserving of rights and dignity. Those two ideas aren't opposed at all. Do you have any comment on that, Andy?
No, yeah, thanks for that clarification. You're right, I didn't mean to suggest that perhaps they were mutually exclusive, but they're two perspectives that do relate to what justification is all about, and this question mark over individual benefit or societal benefit or both. So absolutely right. So thank you for that clarification.
Okay, and the next question. Even if nuclear power use decreases the release of CO2, it increases harmful radioactive materials. Is justification to compare between the benefit of CO2 decrease and the detriment of radioactive increase? Don't we hope both decrease by energy saving and renewable energy?
Very, very, very good question. Very big question. Yeah, so there's several aspects to that question which I could perhaps pick up on. One is how we compare different detriments and different benefits in terms of how you compare CO2 reduction as suggested there with potentially increasing radioactive materials. Now, so you've got some people would argue that the benefit of CO2 reduction is going to far outweigh any small increase in regulated radioactive materials, for example. So some people might come at it from that perspective. But the justification case will have to demonstrate that that is actually the case, bearing in mind, the best available information that we can get on it. So part of that question relates to how you compare different types of benefit and detriment, and also it brings into account the regulatory aspects of radioactive waste and discharges. So there'll still be an expectation, won't there, on the nuclear power industry to apply optimization and limitation to radioactive discharges and radioactive waste. And then the final point there, which is about consideration of alternatives. And I think ICRP, I think I'm right in saying, and someone online will correct me if I get this wrong, but justification is about establishing whether there is a net benefit from the proposed practice. It doesn't really extend into considering whether how that compares to the net benefit of other alternative practices which don't involve radioactive materials or radiation. There is some discussion of that, I think, in IAEA GSG5, I think, but as a principle by itself, I don't think justification covers that within its scope. But it's a very good point, and that will be for national governments to decide on alternatives to nuclear power. For example, it will be for national governments to make that call on whether an alternative energy system it will produce more net benefit. But I think that question, great. I think that final question there really hits the nail on the head, really, about how complex and challenging this whole area is when you look at these, what we've called big picture decisions.
Okay, we have a new question in the chat. On non-medical sector, do we mean justification of using the radiation or the location of using the radiation? I think the principle of justification in medical is different of that in non-medical.
Okay, my understanding is that the justification of principle applies to both. It will apply to both the use of radiation as part of the imaging need and also the location, because obviously that will affect those exposed to that radiation. So I think it's a bit of both. In terms of the principle itself, the principle will be the same at its highest level. At its basic level, the principle will be the same whether it's medical or non-medical, but it'll be applied in a different way. For example, there is a strong presumption on non-medical imaging of it not being justified. So the justification, the onus is on demonstrating that in the exceptional circumstances, national governments may decide that non-medical imaging for airport security or customs and immigration uses is justified or not. And I think Kimberly's coming in with an answer as well, so thank you. Okay, in the meantime, I've got another question.
Okay. So technically large volumes of CO2 cannot be controlled. In the contrary, low volume of radioactive wastes from nuclear power production is totally controllable. By the way, renewable seems that cannot fully support the large industrial needs. So I think this is a follow-up to the previous.
Yeah. It's making the point that as I kind of alluded to, then through technological means or regulatory frameworks, radioactive waste can be controlled, whereas large volumes of CO2 is more challenging. So that's a good point. And then the final point there, it goes on to the big question mark, which societies and governments need to decide on. You know, whether renewables can meet energy needs by themselves or not.
And then building on that same theme, our colleague Daniele has commented, I would add that also most of renewable energy, solar, wind, etc., have an inherent CO2 toll. They don't come for free. A more holistic energy justification should include an evaluation of chemical risks arising from generation of electricity, not only the use of radiation nuclear sources in NPPs.
Absolutely. Yeah, the justification cases, the expectation is that all, as I mentioned at the beginning, all detriments and all benefits so that need to be taken into account. So in the evaluation of net benefit, then we're looking at the net economic benefits and the societal benefits, less the various detriments that Nobuhiko referred to in the beginning. So that will include chemical exposures, it will include noise, it will include transport, it will include land use. All of those detriments will subtract, if you like, from the benefit. And then whatever net benefit is left over, we will then compare, you know, the theory is you compare that then to the radiation detriment. So absolutely, Daniele, all of those considerations need to be taken into account. And that's why, you know, it goes beyond radiological protection expertise per se.
Thanks, Andy. So there's no open questions at the moment. So just wanted to invite everyone to look at the slide and the questions that Andy's provided, if that sparks anything. Oh, and here we go for, and one more question's just come in. Isn't the justification principle redundancy of somehow of the ALAR concept? So very much that optimization concept, and how does that work? I mean, this is what we want to achieve since the beginning is to reduce the exposure. What exactly is new here?
No, I wouldn't say the principle is redundant. It's part of the suite of 3 principles. So justification is looking to ascertain whether there's a net benefit, and then optimization principle then kicks in to ensure that net benefit is maximized. So the two work in tandem. Bearing in mind that optimization and maximizing that net benefit is not about reducing exposures per se. It's about optimizing the overall protection of which radiation exposure is part. So we're digressing here slightly, but one thing optimization is not is dose minimization. Optimization is not dose minimization. It's about optimizing and maximizing the net benefit from the practice, having established that there is a net benefit. And there's nothing new here, by the way, in answer to the question of these principles obviously have been around for a long time, as Nobuhiko said earlier. What we're looking at here is making sure that the application of these principles is as good as it can be. In particular, in an integrated way, justification, optimization, limitation. Ideally, they should be seen as an integrated whole, and not necessarily as a sequential thing. Thank you.
So we have run out of questions and comments, but we still have some time. So Andy, may I ask you a question?
Sure.
So most of questions and comments are related to big picture issues, but this session should cover a broad range of issues. So what about your answers to the second question shown on the slide? How does the justification process vary depending on the scale of the issue?
Yeah, thank you for that. Well, I think if you, I mean, I'll give you my own perspective on this. If you look at the issue going back to the issue of nuclear power generation as a very broad practice. In my view, ideally, that would involve quite an in-depth evaluation across a whole plethora of factors, detriments, and benefits. And it would also need to draw heavily upon stakeholder input, including the public. And from what I've personally seen of across countries, is that level of stakeholder engagement does vary quite a lot. So in those kind of big picture policy decisions or decisions on a whole energy program, then we're looking at potentially quite a comprehensive approach. And on an earlier slide, I put up a picture of an example of the use of a specific technology in the UK, which was justified. We have three different types of new nuclear technology that are now justified. I think it's three, yeah. So that's so you've got policy level where you would envisage wide scale public consultation and a very great input from various forms of expertise. Then if you step down to other uses which are perhaps more focused, so I'm looking at the register of practices from the UK. So you've got things like production of radioisotopes, for example. Now there perhaps which is not necessarily as big a picture as an energy system or energy policy, so therefore that might require perhaps a bit less focus on consultation perhaps, and then you've got sort of smaller uses as well, like use of kind of various screening techniques for security purposes. You've got lightning conductors, which are now deemed not to be justified, the use of radioactive materials for lightning conductors and so on. So I think the scale of the justification process will need to be in proportion to the scale of the decision being made.
Yeah, thank you. Thank you very much. Any other questions or comments from the participants or speakers? No? Oh, another one has come. Julie, please.
Yes, just want to jump in. Are you aware of any research and development being done with respect to integrating even rudimentary dosimetry PRD capability into mobile phones? It seems like there's a large amount of real-time exposure data out there that could be accessed the same way that traffic data has been using a device most people always carry anyways. If there were some way to cultivate exposure data on this scale, it seems like it could advance understanding across the radiation protection field, including justification, broadly speaking.
Answer to the question, no, I'm not aware of any R&D being done with respect to integrating dosimetry into mobile phones. Be interested to hear an answer from anyone else on the call. So I'm not aware of R&D. I think in terms of environmental radiological monitoring, obviously we have in various monitoring systems in place across the world, and monitoring programs around various industrial sites, nuclear power sites, for example. So we have quite a good understanding of environmental exposures anyway, I would say, which do help to feed into evaluations of justification, for example. So That's my initial take on that question, but you know, I'm not aware. I'm sorry. Maybe that's something that someone else can comment on. But thank you for the question.
If anyone wants to add anything on that comment, please throw it in the Q&A while I read the next one. So what you're saying is, I will justify first if I need to use radiation at all or not. Then, if actually needed, I will use the LR concept. But my understanding, for as low as reasonably achievable, is that if it is absolutely needed, then don't. And if it was used, then minimize it as much as you can.
Okay. So yeah, going back to the concept, a new practice that adds radiation exposure does, according to the system of radiological protection, it does need to be justified in advance. And if it's justified in advance, then it's established that whoever the decision maker is, and it might be a national government or it might be a regulatory body, then it's established there is a net benefit, and the practice can be adopted, subject to regulation, of course, and the application of the optimization and the limitation principles. Now, optimization, as I said, the lowest reasonably achievable principle, optimization, take into account social, economic, and environmental factors, still in theory still needs to be applied according to the system. So that's, as I said earlier, that's where the net benefit, we're looking to maximize that net benefit. So I think I've just repeated my previous answer. I'm not sure whether that adds anything to the follow-up question or not.
No, it's great. Thank you. And there is a follow-up to the previous question about the monitoring. So I don't know all the details, but the SafeCast project has GPS data, example in Fukushima. This could be a data source. So thank you very much for that additional explanation. So for the next question, where should the balance sit between justification at a national level, deciding that an activity is something that brings net benefit to society at a strategic level, versus justification of specific tasks at an operational level? It feels we spend a lot of time looking at the first, but not really talking much about the second, instead focusing on operational optimization.
Yeah, I mean, that's a good summary of what happens in practice. So yeah, a lot of time, and I can't speak in depth for other countries, but certainly in the UK, that net benefit is established at the strategic level, as the Chris Jones has said, and then once that's happened and the practice goes on to the register, then that's unless there's any new information that comes in subsequently, then the practice is justified, and then the focus, as you say, is on optimization and limitation.
Andy, could I say something here about
sure
that? Because we do provide the ICRP documents and national referral guidelines in medicine. We provide international understanding of justification and optimization. So but we say adopt and adapt locally, because depending on the time of day, depending on whether your facility is well resourced in a city or you're rural, it may vary considerably what you can do. And so just taking that into consideration, you're going to practice at a different level than the guy down the road. So yes, there's a lot of variation. So you may not have the expertise or the kind of equipment that your neighbor has. So that's why, you have to take those things into consideration. And your patient population may differ too. So there is a lot of variation in how medicine is practiced. So I wanted to bring that up. And that's why we talk about these things. And we make the caveats that we do. But there are some general principles about justification and certainly about optimization that are, always the case.
Thanks, Kimberly. Yeah.
So I see one last question in the chat, and then we'll pass it back to Nobuhiko. So from these discussions, it seems that justification is very country specific. What if they justify such that dose limits do not apply anymore?
Well, that would be for individual countries to decide, obviously, under their jurisdictions. What I can say is that the IAEA safety fundamentals do include justification. I think it's number 4, I think. So, so countries that are signed up to the international basic safety standards theoretically should apply the justification principle, and then there's principles under the IAEA BSS which talk about optimization limitation as well. So there is a global expectation that that countries apply dose limits in addition to justification and optimization. So but at the end of the day, we were talking about national sovereignty and jurisdictions, then of course it's not impossible that dose limits could be ignored, I suppose, but that's not generally the case.
Great, thanks Andy for answering all those questions for us. Nobuhiko, please, the floor is yours.
Yeah, thank you, Andy, for your contribution. And I would like to thank all the participants for your many comments and questions. And now it's time to declare the end of today's program, but we have other 2 sessions tomorrow. We will discuss about emergency exposure situations and existing exposure situations. So I'd like to ask all of you to join tomorrow again and to post many questions and comments. Thank you for your attendance. Thank you very much.